This is best practices for musculoskeletal medicine. So if you are watching this at home, this is based on systematic meta-analyses and huge reviews of the literature looking at what actually works best for patients. I would screenshot this. I put this in all of my books from now on. This is research from 20 years ago to up to current research. So the key things that we want to focus on for best practices, and then I'm going to break down each of the conditions individually as we go through this. So first thing is motivational person-centered care, screening for red flags. Our first and primary goal as healthcare providers is to rule out red flags of more serious pathology. So what are some of these more serious pathologies that we have to worry about? Well, a standard example would be something like cancers or unexplained weight loss, if you're looking at that, or more significant inflammatory processes that we need to have emergency involvement with, or things that have the risk to progress and become worse as well. What does motivational person-centered interview mean? Most of us are doing this automatically anyway. It means that you are paying attention to the patient, valuing their beliefs and goals, and focusing on what matters to them most. What's the best for the benefit of the patient? The next thing we're going to do is assess biopsychosocial fears, beliefs, and evaluating goals. For every patient evaluation that I'm doing now, literally, my questions are always at every visit, what are your goals for today's visit? Okay. Sometimes you will be surprised with that, but basically focusing on your goals. And one of the key things that underlies all of this as well is sleep hygiene. How many hours a night are you sleeping? Are you feeling well rested when you wake? If somebody doesn't sleep good, all manifestations of any pathology are worse. Sleep is foundational, and sleep can actually directly be related to their ability to exercise and get activity during the day. Next thing that we're going to talk about is going to be assessing mobility, strength, and neurologic function. Well, how do you assess this? The simplest way, and I do this with every patient, almost every visit, a simple active range of motion assessment is going to be one of the key ways that you can do this. So active range of motion assessment. Then we can go ahead and move on and look at neurologic function if it's required, if they have any numbness, tingling, or weakness or shooting electrical pain. And then we're going to focus on outcome markers, okay, and key outcome markers. And we can go ahead and toss up a list of key outcome markers, but you can make it up yourself. The most common ones for musculoskeletal pain are pain level and range of motion and activities of daily living. But another one that I really like to put out there for everybody is medication intake. If I can lower your medication intake, I know that I am helping to make you better. I shouldn't say I'm making you better. We're working together to find solutions that you're seeing resolution of your symptoms with, or decrease of your symptoms with. The next thing is providing educational material. And in fact, the research is abundantly clear on this. What is the most important thing we do for all of our patients and clients? Education, number one, empowering to believe and getting them to do more than they think they can. And then we can go through our other activities, education, empowerment, and then deciding what you're going to do for manual therapies. Diagnostic imaging, absolutely positively overrated by a number of patients and practitioners. There is a poor correlation to what you see on a film or MRI or X-ray or ultrasound or you name it, or blood tests, whatever it actually is, and the direct correlation to what's going on with that patient. The problem especially is if you only look at radiology reports. For a lot of doctors and therapists who look at radiology reports, they're not seeing the original imaging. So it means that they actually don't know what the picture of the person looks like, and they're looking at somebody else's interpretation of that image. Radiologists typically do not see patients and cannot correlate physical exam findings with imaging findings. You can do that as the clinician, but it works better if you see the original imaging and know how to interpret it. Key things here, the only time I'm really doing imaging is if I'm lost or if it's going to change my differential diagnosis to help rule in or rule out a condition. The next and most important thing as well is going to be diet assessment, modification, and education for your patients. It is amazing how many people do not realize how their diet affects every aspect of their life. Why did we write the nutrition book? That book is written specifically for patient education and to give for doctors and therapists to give to their patients so they can educate people better on basic nutrition and the most common 30 diets that we see right now as well. And as we were talking about before, another key thing for us to get is graded activity exposure. And that's what we're looking here. The case example that I gave of the guy with low back pain at the very start, His was a graded activity exposure. 6 months of chronic low back pain, 2 months off work and not getting better. He has reached a plateau. And within that plateau, there's lots that we can do to help break that cycle, but it has to be a graded exposure of education and empowerment, and then focusing more on the exercise. And all of this overlays with our manual therapies, okay? Any other hands-on treatment or assessments that you want to do are absolutely going to offer benefit if they are used in conjunction with other evidence-informed therapies that we've mentioned here previously. All right. And that's the key thing to get right there. Manual therapies do offer benefit when used in conjunction with other therapies.